Thank you so much for the invitation to present preterm birth prevention, what is the evidence, to the 10th annual virtual conference of maternal fetal medicine. I am Amanda Roman. I am associate professor of maternal fetal medicine at Thomas Jefferson University Hospital in Philadelphia. I have no financial disclosures. The preterm birth in the United States continues to be a big problem. The rate of preterm birth less than 37 weeks in singleton pregnancies is 8.2%, while in twins is 16%. While the bulk of preterm birth is late preterm birth from 34 to 37 weeks, the higher risk is extreme preterm birth less than 28 weeks. They have higher neonatal morbidity and mortality. Delivery before 28 weeks increase the risk of respiratory distress, sepsis, intraventricular hemorrhage, and necrotizing enterocolitis. The preterm birth is a syndrome. One woman don't have just one risk factor. They have a constellation of risk factors and markers that will lead towards spontaneous preterm birth, preterm rupture of the membranes, and some will have a medically indicated preterm delivery. The risk factors for preterm birth are very long list. They include sociobiological variables, maternal medical conditions, past obstetrical and gynecological history, and characteristics of the current pregnancy. During this lecture, we're going to focus on history of preterm birth, short cervical length, and multiple gestations. In singletons, the history of preterm birth varies from 17 to 50%. The variation depends on the demographics of the publication, associated risk factors. They also impact on whether the prior preterm birth was a singleton or a twin, and the number of preterm birth, one prior preterm birth, 2 or 3. The gestational age of the prior preterm delivery also will impact on the risk of the current pregnancy. If a woman had a history of preterm delivery less than 28 weeks, there will be a recurrence risk of more than 13 times to deliver again less than 28 weeks. In twins, the history of preterm birth has been informed as at 10%. However, that will increase the risk of preterm delivery from 50% to 80%. And also, the gestational age of the delivery of the prior pregnancy will impact on the twin pregnancy. And if a woman had a history of preterm delivery less than 32 weeks, that will increase 10 times the risk of preterm delivery at the twin pregnancy. Monochorionic twins have an increased risk of spontaneous preterm birth compared with diachorionic twins. Monochorionic twins is not just an indication for fetal reasons. They also have higher risk of spontaneous preterm delivery less than 37 weeks and less than 34 weeks. Monochorionic twins are also associated with shorter cervical length compared with diachorionic twins. The cervical length measured by ultrasound has been shown to be one of the most predictive screening tests for spontaneous preterm birth. This is a multi-center study, prospective study that showed the association between the length of the cervix and the risk of spontaneous delivery. They determined that the shorter the cervical length, the higher the risk of preterm delivery. And they determined that 25 millimeters represents the 10th percentile, while less than 15 millimeters represents less than the 5th percentile. The risk of preterm birth by transvaginal cervical length and gestational age diagnosis was evaluated in this retrospective study in a population at high risk. They have history of preterm birth, mutilating abnormalities, pregnancy loss, and DNCs. The association of the cervical length, for example, 10 millimeters diagnosed at 16 weeks had a 55% risk of preterm delivery less than 35 weeks, while the same 10 millimeters at 24 weeks will be associated with a 45% risk of preterm delivery less than 35 weeks. We also evaluated women with singletons and low risk, no prior preterm birth. The shorter the cervical length and the earlier the diagnosis between 16 to 20 weeks was associated with a higher risk of preterm delivery at any gestational age evaluated. This evaluation was also applied to twin pregnancies. This IPD meta-analysis of almost 5,000 women showed that the shorter the cervix and the earlier of the gestational age of diagnosis will increase the risk of preterm delivery. The cervical length should be evaluated by transvaginal ultrasound. The transabdominal cervical length has low reliability. The bladder needs to be adequately filled to identify internal os and external os. Fetal parts can obscure the cervix. There is a longer distance from the probe to the cervix. Obesity will obscure as well the identification of the cervix, which is one of our major problems. Our population had a BMI more than 30 and a 50%. Most women undergoing transabdominal cervical screening will need transvaginal evaluation anyway. 6% of women screened by transabdominal cervical length could not be visualized, and they will need the evaluation. Moreover, 4 to 7% of short cervical length by transvaginal ultrasound will not be detected at all by using transabdominal screening. There is a proven treatment of women identified with short cervical length. Therefore, the medical societies have endorsed the transvaginal ultrasound as the gold standard for the cervical length screening. Let's evaluate prevention for preterm birth strategies. I want to briefly mention the low-dose aspirin. This is a prospective randomized clinical trial, placebo-controlled. They give 81 milligrams of aspirin to women with singleton pregnancies and no prior preterm birth and low risk. They started the medications from 6 to 12 weeks, and the outcome was a significant decrease of preterm birth less than 37 weeks by 11%. More importantly, there is a decrease of early preterm birth less than 34 weeks by 25%, and early preterm delivery associated with hypertensive disorders was decreased by 62%. Progesterone. The natural progesterone binds with the receptors in the uterus and the cervix. In vivo and in vitro studies have demonstrated that the natural progesterone affects the cervical remodeling and the shortening of the cervix, inhibits the uterine and myometrial contractility, and reduces inflammation and immune activation. The vaginal progesterone undergoes a uterine first pass, while the oral progesterone undergoes a liver first pass effect. 17-hydroxyprogesterone caproate lost the FDA approval for the prevention of preterm birth in the United States in April 2023. Since then, we have been focusing on the vaginal progesterone for the prevention of preterm birth. This is a meta-analysis comparing the vaginal progesterone and the intramuscular progesterone. They included women with singleton pregnancies and prior preterm birth, 7 randomized controlled studies with 1,900 women. They identified that it was a significant decrease and benefit with the vaginal progesterone to decrease preterm birth less than 34 and 37 weeks. However, when only low-risk bias studies were evaluated, there was no significant differences. When vaginal progesterone was evaluated in singleton pregnancies with no prior preterm birth, but cervical length less than 25 millimeters, they included 5 studies of high quality with 974 women. They identified that the vaginal progesterone significantly decreased preterm birth less than 33 weeks by 38%. In a secondary analysis, they also identified a significant decrease of preterm birth less than 36 to less than 28 weeks, a decreased risk of respiratory distress syndrome, composite neonatal morbidity and mortality, birth weight less than 1,500 or less than 2,500, and a decreased incidence of admissions to the neonatal intensive care unit. In a meta-analysis comparing vaginal progesterone with placebo or no treatment in women with single pregnancies and a history of preterm birth, they included 10 studies with 2,958 women. The vaginal progesterone doses varied from 90 milligrams to 400 milligrams. This meta-analysis concluded that the vaginal progesterone significantly decreased the risk of preterm birth less than 37 weeks by 36%. In the sub-analysis, they also identified a significant reduction of preterm birth less than 34 weeks by 38% and admissions to the ICU by 47%. The number needed to treat goes from 17 to 28. Additional meta-analyses have reported similar benefits to vaginal progesterone versus no progesterone in the reduction of preterm birth in patients with a prior preterm birth. IPD meta-analysis of non-trials found a significant reductions of 22% and improved neonatal outcomes in the EPIC group. And the National Institute of Health and Care Excellence in the United Kingdom conducted their own meta-analysis and identified vaginal progesterone reduces preterm birth less than 34 weeks in women with prior preterm birth. The effect of progesterone on cervical shortening was evaluated in one randomized trial. This is a secondary analysis on women who had received vaginal progesterone 90 milligrams versus placebo. They had a transvaginal cervical length at baseline, 18 to 22 weeks, and again at 28 weeks. They identified that women who received progesterone had a significant less incidence of short cervical length, less than 25 millimeters and less than 15 millimeters. In the twin pregnancies, vaginal progesterone was evaluated in this systematic review. They included all twins, independent of the cervical length. 11 studies, 3,400 women. They identified no significant differences in the incidence of preterm birth less than 34 weeks. When they included only women with twin pregnancies and cervical length less than 25 millimeters, these six studies with 95 women identified a significant reduction of the preterm birth less than 32 weeks, 30 weeks, and 28 weeks, and a decrease in composite neonatal morbidity and mortality with a number needed to treat from 4 to 7. The quality of evidence was moderate in all of these outcomes. The dose of progesterone is difficult to recommend a single dose of formulation, as all the RCTs have used a variety of doses. They go from 100 to 400 milligrams of progesterone suppositories, 90 milligrams of progesterone gel, or 600 a day in the twin study. The meta-analysis have found a similar risk reduction with different formulations and with different dosages. The data from the randomized clinical trials reveal no major side effect or risks, and the vaginal progesterone only was associated with increased vaginal discharge, and it was well tolerated. Long-term studies have shown safety for neonate and child. The society guidelines, ACOG, SMFM, and different countries have supported the use of vaginal progesterone in women with singleton and prior preterm birth and short cervix. They inform of to consider or to recommend and to discuss with the patient for a shared decision-making depending on the risk factors of the woman. Cerclage in singleton pregnancies. The history indicated cerclage had been applied historically to women who had history of preterm birth, especially those who had prior painless advanced cervical dilation or associated with either pregnancy loss or extreme preterm birth. In trials in women who had only 1 or 2 prior preterm births have not shown benefit from history indicated cerclage. They only show benefit for those who have 3 or more prior preterm births or a second trimester pregnancy loss. The cerclage decreased the preterm birth less than 32 weeks from 32% to 15%, and they decreased by 50%. So at this moment, we are only considering history indicated cerclage for women who had history of advanced cervical dilation or who have had more than 3 preterm births. In women who had singleton pregnancy and history of preterm birth, the cerclage for women with cervical length less than 25 millimeters was evaluated in this multi-center randomized clinical trial published in 2009. They included, the results of this study showed a significant decrease of the preterm birth less than 35 weeks by 32% in the cerclage group. And in the subgroup analysis of women who had a cervical length less than 15 millimeters, there was a reduction of preterm birth less than 35 weeks by 77%. In this subgroup analysis, they showed that the incidence, the benefit of the cerclage was higher in women who had shorter cervical length. And this will assist with the counseling of women. This meta-analysis of IPD meta-analysis in singletons with prior preterm birth showed that the subclass had a significant decreased risk of preterm birth less than 37 and 35 weeks and 32 weeks. In women who had a prior second trimester loss from 16 to 23 weeks, there was a significant reduction in the preterm birth less than 35 weeks in women who had subclass. And there was no reduction in those who only have cone biopsy and short cervix or DNE and short cervix. In women who had singleton and no history of prior preterm birth and cervical length less than 25 millimeters, we evaluated these women from 5 trials, 419 women. They did not receive any progesterone supplementation. We evaluated the risk of preterm birth, subclass versus no subclass at different gestational ages, and we identified no significant difference, no improvement in the subclass group. When we evaluated by cervical length, there was a significant reduction in the preterm birth less than 35 weeks by 32% in the group who had cervical length less than 10 millimeters. These women also received tocolysis with indomethacin and antibiotics during the subclass. Therefore, the combination of subclass, indomethacin, and antibiotic in women who had cervical length less than 10 millimeters may benefit from subclass. At this moment, we are doing a randomized clinical trial in this subgroup of women, singletons with no prior preterm birth, cervical length less than 25 millimeters, subclass versus no subclass, plus indomethacin and progesterone as a standard of care for all women. We are awaiting for results of this trial. When discussing progesterone and subclass together, there is a meta-analysis that compares the vaginal progesterone is as effective as cervical subclass to prevent the preterm birth in women with prior preterm birth and short cervix. The result of this study showed that the vaginal progesterone decreases preterm birth less than 35 weeks by 28% versus subclass at 30%, and there was no significant differences in the two groups. The conclusions of the study is that you could choose one or the other to prevent preterm birth. If we look at the table for the secondary analysis, the preterm birth less than 32 weeks was similarly 40% for progesterone group versus 34% for the subclass group. However, the preterm birth less than 28 weeks was not significant in the subgroup of the group of vaginal progesterone, while the subclass group remained a significant decrease of 36%. There are no direct randomized clinical trials comparing progesterone versus subclass or in the same trial or progesterone and subclass together. And therefore, this is a retrospective multi-center study by one of my colleagues, Dr. Bolek and Dr. Tolosa. They evaluated women who had singleton pregnancies and have had cervical short cervix less than 25 millimeters and subclass plus progesterone versus subclass alone. They identified that the combination of progesterone with subclass significantly decreased the risk of spontaneous preterm birth less than 37 weeks, less than 34 weeks by 40%, less than 28 weeks by 45%, and less than 24 weeks by 50%. They also had a significant prolongation of the gestational age in weeks and decreased the perinatal mortality by 60%. Subgroup analysis evaluated the different formulations of progesterone, identified that vaginal progesterone, 17-hydroxyprogesterone versus no progesterone, and the survival curve favors progesterone supplementation plus subclass. In a subgroup analysis showed that the 17-hydroxyprogesterone was not in favor of decreasing preterm birth, while vaginal progesterone plus subclass decreased preterm birth. The type of subclass was evaluated as well. There was no significant differences in history-indicated subclass. However, in ultrasound-indicated subclass, there is a significant reduction of preterm birth in the association of progesterone and subclass, and especially a decrease in the exam-indicated subclass, which favors both combinations, progesterone and subclass. Let's move on to subclass in twin pregnancies. In 2012, this practice bulletin informed of the high risk preterm birth associated with the placement of cerclage. This is a publication in the 2005 systematic review of 49 women included in other randomized clinical trials. When we evaluated these 49 twins in an IPD meta-analysis, we identified that there were differences in the demographics. There were higher risk of history of preterm birth, and the gestational age at the diagnosis. Therefore, after adjusting for those confinders, we identified that there were no significant differences in comparing cerclage versus control. There was no improvement, but there was also no harm. There was seen that there were higher risk of respiratory distress syndrome in neonates in the group of cerclage. Other evaluations, other studies have been evaluated this topic. Twins with short cervix, less than 25 millimeters, in retrospective studies have shown a significant reduction of 25% in the preterm birth less than 34 weeks and 33% in the preterm birth less than 32 weeks. In the subgroup analysis of women who had cervical length less than 15 millimeters, there is a significant reduction of preterm birth less than 34 weeks by 30% and less than 32 weeks by 37%. But remember, these are all retrospective studies. At this moment, we are randomizing women with twin pregnancy and cervical length less than 15 millimeters to cerclage plus vaginal progesterone versus no cerclage and vaginal progesterone. We require 200 women, and we are enrolling. The physical exam indicators are cerclage in twin pregnancy. There is only one randomized clinical trial. We evaluated women with twins and dilated cervix from 1 to 5 centimeters cerclage versus no cerclage. The results indicated that the physical exam indicators cerclage significantly reduced the preterm birth at all evaluated gestational age from less than 34 to less than 24 weeks. There was a significant prolongation from diagnosis to delivery by 5.6 weeks, and overall reduction of perinatal mortality by 77% with a number needed to treat of 4. Other retrospective studies evaluating twins with dilated cervix indicated that the cerclage significantly decreases the risk of preterm delivery less than 34 to 24 weeks with a pregnancy prolongation of 6.7 weeks. In conclusion, and summary of recommendations for women with a singleton pregnancy and no prior preterm birth, we prescribe low-dose aspirin around 12 weeks. We offer universal transvaginal cervical length at 20 weeks. If they're being identified with a cervical length less than 25 millimeters, we offer them vaginal progesterone 200 milligrams, and we offer them participation to our randomized clinical trial. If a woman with a singleton pregnancy and prior history of preterm birth, we offer them vaginal progesterone daily, starting at 16 weeks up to 36 weeks. Simultaneously, we offer them serial cervical length from 16 to 23 weeks. If they're identified with less than 25 millimeters, we offer them ultrasound indicator cerclage, and then we continue with the vaginal progesterone. If they have a cervical length more than 25 millimeters, we continue with the vaginal progesterone at 36 weeks. If they have a twin pregnancy, we offer them low-dose aspirin, serial cervical length from 16 to 23 weeks. If they are identified with a cervical length less than 25 millimeters, we offer them vaginal progesterone 400 milligrams until 36 weeks. And if they are identified with a cervical length less than 15 millimeters, we offer them participation to our randomized clinical trials, twins with short cervix. Thank you so much, and I'm available for questions.